15-year-old girl was experiencing high-grade fever for the last 6 days. She noticed severe pain in right knee, followed by the redness and swelling since 3 days. She arrived in OPD with a central chest pain accentuated on inspiration. On examination, the temperature is 101 degree, the pulse 117 per minute, the blood pressure is 100/67. Right knee was red and swollen with restricted movements. A harsh scratch sound heard at the 6th intercostal space on the left side of the anterior axillary line, which is accentuated on pressing the stethoscope. The hemoglobin at this time was 12.7 gram and total leukocyte count is 13,200, platelets is 4,38,000, ESR is 58, the random blood sugar is 78 milligram, and X-ray of the knee was swollen and the periarticular tissues. It showed as a plain X-ray. It showed the swollen joint and the fluid is seen in the periarticular tissues. My self-introduction is I am Professor Ali Haider presenting this case in front of you. I am visiting professor of medicine at the Janashin Medical University. I always start with a scenario, clinical. The final year people, they are clinical people, because after few months you have to see the patients. And this type of the case will be presented often, you will see in the OPDs. Now taking the soft data, this is a young girl with a fever and the pain on the knee, and she has a central chest pain. She has tachycardic and she has slightly hypertensive, and she has got the ESR which is raised, with platelet count which is also higher side, and there is leukocytosis. The hard data of this problem which is given is the joint which is involved. So it is red and swollen. It is not arthralgia, it is arthritis. A very short period of time. She had not given any other history before. Past history was not given or not taken properly. There is a harsh stress sound which is at the 6th intercostal space on the left side of the anterior axillary line, which is accentuated on pressing the stethoscope, which signifies that the pericardium is involved in this case. She is suffering from some type of acute pericarditis with knee involvement, with the acute phase reactants which are increased. That is, THC is increased, platelets is increased, ESR is increased. And there is evidence of the inflammation on the radiology of the right knee. This is the hard data. So the question is, the differential diagnosis is concerned. Primarily it is a monoarthritis, of course. The one joint is involved here. Differential diagnosis of a monoarthritis. How will you further investigate what is the most likely diagnosis and how will you manage? We discuss now. Already soft data and the hard data I have already presented in front of you. In this, your differential diagnosis may be possibility of many things. For migraine is concerned, it may be the post-streptococcal reactive arthritis, which is non-migratory type. It may be rheumatic fever itself, rheumatoid arthritis, systemic lupus erythematosus. It may be infective endocarditis. It may be sickle cell disease, which is involving the joint, involving the some part of the heart or the chest rather. The drug reactions can cause this type of a scenario. Tuberculosis, the Lyme disease, you know about it, it's parochial disease. Broria burgdorferi, Lyme disease. Lyme disease is seen in some part of Pakistan, which is near to the China. And serum sickness. This is a suggested differential diagnosis. Mine is concerned, the most important is a young girl, very short history of arthritis and high acute phase reactants with evidence of the acute pericarditis. I suggested the diagnosis should be very near to the rheumatic fever. How I will, justify it. I justify on the basis of the Jones criteria, modified Jones criteria. Diagnosis of this is that we need two major criteria, one major and two minor criteria, plus supporting evidence of the antecedent group A streptococcal infection. There should be the evidence of a group A streptococcal infection in this patient, plus the major criteria or minor criteria. The major criteria is the carditis. Carditis should be pancarditis. It means that pericarditis, myocarditis and endocarditis. Polyarthritis, chorea, erythema marginatum, and subcutaneous nodule, which is called rheumatic nodules. The minor criteria, clinical findings, and the lab findings. The clinical findings are fever, arthralgia, not arthritis. The lab findings, elevated acute phase reactant like ESR or C-reactive protein or thrombocytosis, etc. The prolonged PR interval on the electrocardiography. Supporting evidence of the antecedent group A streptococcal infection is ASO titer. In Pakistan, if it is more than 1:250, it is with higher titer or titer. Now, new antibodies are also described. Anti-DNase B antibodies, anti-hyaluronase antibodies, and other antibodies are also being described. Plus, the easiest thing for the support is the throat culture or the rapid antigen test for the group A streptococci. It is very easy to do it. In this girl, most probably she has got the evidence of the major criteria and the minor criteria. If you calculate it, it is very near to the diagnosis of the rheumatic fever. Only thing is that you have to do the investigations and prove the antecedent streptococcal A infection. Definition of the rheumatic fever is an inflammatory process which can involve the joints, heart, skin and brain. It is caused by the antibody cross-reactivity and occurs 2 to 3 weeks after a group A streptococcal infection. Most commonly, the sore throat occurs 3 weeks before. It came and goes. And the antibiotic was given and the patient was alright. The most important theory is this, that the streptococci, they multiply at the site, and the cross-reactivity occurs of the antigens of the streptococcus group A streptococci, and they produce antibodies. Now these are the very, very unique type of antibodies. Now the structure of the group A streptococcus, some part of it, is very, very similar to the structure of the endocardium. That is why the mitral valve is involved, because they are very, very near. The characteristic, microscopic characteristic features or antigenic similarity between the streptococcal antigens and the endocardial antigens, they are very similar. So they cross react after 3 weeks. After 3 weeks they cross react. Also they are also acting on the synovial of the joints. Even the other serous membranes can be involved because of the cross reactivity. And this is the most clinical manifestation of the acute rheumatic fever. The commonest is the polyarthritis. Now this is very important, polyarthritis. It is a migratory type of polyarthritis. Wandering type of a polyarthritis. One joint is involved and it resolves completely. Then the other joint involves after a few days, and then it remits. And the third joint involved after 4 or 5 days. So it is a migratory type of a polyarthritis. Not polyarthritis, but it is a migratory polyarthritis. Secondly, carditis. Carditis in this case is pancarditis. Basically, the pericardium is involved, the myocardium is involved. The evidence of the myocardial involvement is the increased heart rate. And the endocardium is involved. The endocardium involved, the mitral valve is involved, it is inflamed initially. So the pancarditis means the 3 layers of the heart is involved. This is the only disease in the world which can cause the 3 layers which are involved. The second disease which can cause is the acute myocardial infarction, which can cause the inflammation and destruction of the 3 layers. Then erythema marginatum, that is the specific type of the cutaneous manifestation. Chorea, the central nervous system involved. Again, they said this is probably a part of vasculitis because it is an autoimmune disease. Subcutaneous nodules, again, is a part of it. It is the rheumatic nodules which is present at the pressure points of the different parts of the body. You will feel that at the elbow or at the anterior of the hands, interphalangeal joints. Now, subcutaneous nodules may be present. It may be present in some cases, but it's very rare. It's not seen commonly. I have seen only one case in my life. Epidemiology is, at one time, I said that in 1960 and 70, it is much. Now it is reducing in the world because of the people, they know that this disease is a crippling disease. They come to the doctor early, the doctor manage it on the recommendations given by the WHO. So awareness was there, and there is, of course, the disease is now going down and down. Still you see the cases at the age of the 30 years or 40 years of the mitral valve diseases. At that time, in the early ages, they got sore throat, streptococcal sore throat. At that time, they the diagnosis was not made, and after 20 to 30 years they presented with some mitral valve disease or some aortic valve disease. Primarily, the children, definitely I said they are the children, they are affected. And 2 to 3 weeks after group streptococcal infection, that is streptococcal sore throat or scarlet fever, it is also a streptococcal A infection, can cause it. But very, very, unique thing is that the streptococcal infection of the kidneys will not cause rheumatic fever. And the other infections of the skin, which is caused by the streptococcus, will also not cause the rheumatic fever. Globally, 3% of those with an untreated streptococcal infection develop rheumatic fever. Overall, 3% untreated, and 40% of those with acute rheumatic fever develop the mitral stenosis as adults at the age of 30 years or 40 years. I already said that. They are coming at the age of 30 years and 40 years with the mitral valve disease. And I already said the cutaneous infection will not cause this infection. The infection of the kidney will not cause the infection of the streptococcal infection of other areas will not cause the rheumatic fever. Basically, there are two diseases. One is sore throat, secondly scarlet fever can cause it. The pathophysiology, I already said that this is the mimicry of the antigens between the streptococcal streptolysine S or O and the antigenicity resembles the synovium or the endocardium. That's why the injury occurs with the antibodies. And the other theory is that serum sickness-like reaction mediated by the antigen-antibody complexes. And thirdly is the autoimmune, basically the autoimmune phenomena. Because there is no evidence of the streptococcus A after 20 years or after 30 years. There is no evidence. It is autoimmune phenomena because it causes the vasculitis also. Because this is causing the vasculitis, and the thing is the chorea occurs in this condition, which is not due to the autoimmune, the autoantibodies which is acting on the brain. It is the vasculitis which causes the chorea. The more support of the autoimmune phenomenon, type 2 hypersensitivity reaction are there, and the presenting cells present the bacterial antigen to helper T cells. These antibodies can also interact with other cells in the body, myocardium, joints. I already said that because of it is the antigen mimicry. They have got the same type of the antigen. This is the case of very, very common streptococcal sore throat. And it is the hemolytic streptococci group A, which is seen in this diagram. The most patients have elevated antibody titers or at least one streptococcal antibody, the streptolysine O or hyaluronidase or streptokinase. Pathophysiology, cardiac is concerned, you feel the basic problem in the biopsy is Askov nodule. You see it with the owl-eyed shape in the cross section and the caterpillar shaped in the longitudinal section. In this slide of it is electron microscopic slide which is in front of you. Everything is clear here as Askov nodule is concerned, as a nodule which you are seeing here. The cardiac thickened fuse called the tendinae of the mitral valve is seen after the inflammation, destruction occurs, of the mitral valve. I already mentioned out when I said about the valvular heart diseases. Now, clinical manifestations, the latent period between preceding streptococcal pharyngitis and acute rheumatic fever is about 19 days. It may be more than that. Let's say the 3 to 5 weeks. It ranges 1 to 5 weeks, but in Pakistan it is 3 to 5 weeks. If initial complaint is polyarthritis, the disease generally has more abrupt onset compared to if initial presentation is myocarditis. Abrupt onset is if there is polyarthritis. Otherwise, it is a very slowly progressive disease. Arthritis occurs in 75% of the initial attacks. Carditis in 40 to 50%. Chorea as a presenting feature is 15%. Subcutaneous nodules and erythema vaginatum is less than 10%. Carditis is concerned, I already mentioned about it, that usually manifests within the first 3 weeks of the acute rheumatic fever. New heart murmur occurs at the mitral area. It is inflamed and it is called Carey-Coombs murmur. Inflamed mitral valve is a diastolic murmur, and the scratching sound, it is a blowing type of a sound you see in the diastole, a short diastolic murmur. But it is not that the murmur of the mitral stenosis. There is a signs of the cardiomegaly or the congestive heart failure, pericardial frictional drop because of the pericarditis and effusions. Pericardial effusion can occur. Chronic inflammatory changes may lead to the development of the rheumatic heart disease. So the patient becomes, one valve may be involved, there may be 2 valves, maybe 3 valves, maybe 4 valves. All valves are involved. In most of the cases, it is the mitral valve. In 20 to 30% cases, it is mitral valve plus aortic valve. And in only 5 to 10% of cases, it is the pulmonary valve and the tricuspid valve which are involved with mitral valve. So the characteristic murmur of the rheumatic heart disease is the mitral regurgitation afterwards. It is a prolonged mitral stenosis, low-pitched mid-diastolic flow murmur at the apex, the Carey-Coombs murmur I said, is the mitral because of the inflammation. And there will be aortic regurgitation along with it because of the involvement of the aorta. It can also get the AV conduction delays because the myocarditis will cause the delay in the PR interval. It will delay of the PR interval as the evidence that the myocarditis occurs. It is the initially the tachycardia, sinus tachycardia also signifies the myocardium involvement. This is how the heart is seen. At autopsy it is wholly red. You see, it is shining red heart. And there are different parts are seen in the heart. You see the lesions, they are on the surface of the heart. They are background, red background around with the pale in the middle. And they are ascope nodules actually. You see morphologically. The carditis, I said that the 3 layers are involved: pericardium, the myocardium, and endocardium. This is the evidence of the cardiomegaly on the radiology. As you see, it is a big heart here. In this diagram, the pericardial effusion is also manifested. Because of the hilum overlay sign, the hyla are not visible. And PR interval, if you calculate the PR interval, as mentioned in here, from P to the R, it is 0.20 second. PR interval is increased. Even afterwards, if the myocarditis is worse, that it can go to the second heart degree AV block or third degree heart block. The complete heart block can occur if it is severe myocarditis. I see in the lead number 2, which is the rhythm lead, you see the P rate varies with the R rate. There are extra P waves are seen, and there is severe bradycardia. This is AV dissociation, which can be seen in severe type of rheumatic carditis. Joints are involved. I already said the migrative type of the polyarthritis, warm, sole and tender joints involving the knees, the ankles, the elbows and the wrists. The big joints are involved, not the small joints are involved. It lasts 2 to 3 weeks. See the red swollen inflamed joints here, and pain and the movements of the elbow, at the wrist, at the ankle. And this is the morphologically, which is inflamed membrane and swollen joint is seen here, and eroded cartilages and the narrow joint space if you open it. Skin lesion, there are 2 types of skin lesion. One is subcutaneous nodule, rheumatic nodules associated with the severe carditis and occurs several weeks after the onset. It is firm, it is painless nodules up to 2 cm found over the bony surfaces and tendons, pressure points. Now occur near the elbows or knees, the wrists or the Achilles tendon and the vertebral joints. It usually persists for 1 to 2 weeks. As you see here, it is elbow probably. I seen the nodule, subcutaneous nodule. It is painless nodule which you see. Probably it is a manifestation of the vasculitis. So these are also present on the back in this patient. They differentiate with the erythema nodosum, which is present only on the shins. They are almost red and it is tender, erythema nodosum. So you have to differentiate between the rheumatic nodules and the erythema nodosum. The other lesion of the skin is erythema marginatum, which is a very rare one. It is non-pruritic, it is painless erythematous rash on the trunk and on the proximal extremities. They are macular lesions with the raised margins and the central clearing. They may last for weeks to months. Now see here this type of a lesion, which is a circular region around, it is reddish, and the center there is paleness occur. It is non-pruritic. It is seen in 5 to 10% of cases only. And back, the trunk, the torso are involved. And these are the back, which is seen here with this the anterior chest wall. There are many erythema marginatum are seen in this patient. Now, clinical manifestation in neurological involvement is Sydenham's chorea. Sydenham's chorea, the specific chorea which is seen in this disease. Neurological disorder with the muscular weakness, emotional lability and involuntary uncoordinated purposeless movements. They disappear during sleep, mainly occur in the hands, feet and the face, but sensations are intact and last 2 to 4 months. Remember that this Sydenham's chorea is a painful chorea. This is only chorea which is painful. Otherwise the Huntington chorea and the other choreas are there. There is differential diagnosis of the chorea. There are many causes of the chorea, but they are not painful. Purposeless movements are there, but the patients have got no pain. In this condition, in Sydenham's chorea, there will be pain. You will, when the movement occurs, uncoordinated, purposeless. This is the observation which I have done in 2 to 3 patients. And secondly, remember, if there is syndhymes chorea without evidence of any other things, there are chances of mitral valve disease or the involvement of the heart after 30-40 years of this syndhymes chorea. Syndhymes chorea means that heart will be involved in future. This is the rule of the syndhymes chorea. And it is written in the Harrison textbook of medicine that if somebody has got syndhymes chorea as a major manifestation and there are other minor manifestations, and you diagnose as acute rheumatic fever, but the heart is normal at this time, the patient will be involved after 20 to 30 years with the diseases of the valves of the heart. This is very, very important point. Now, syndhymes chorea is visible here. It is a dancing type of a thing. People laugh to see these babies. They are dancing, but they are not dancing. They are unwanted purposeless movement, but they are painful. If you want to stop it, it will become, the patient says that it is painful. Do not do it. Do not touch. This is the Indian boy which has got the syndhymes chorea of the left limb, which is visible here. And if you want to stop it, it is very painful. The causes of chorea, other than that, the drugs can cause it. The vascular diseases of the basal ganglia can cause this. The degenerative diseases like Huntington's chorea, post-infectious, already syndhymes, I have said. The other causes, thyrotoxicosis, can cause chorea. But these all other types of the chorea can be managed if the primary disease is managed. It will be gone. Only Huntington's disease is a problem, which is associated with dementia. Otherwise, other diseases can be managed if the primary etiology is removed. Now, Jones criteria, I already mentioned how it is the two major and the one minor criteria. And it is a very great work done by the Jones in 1944. And afterward, the other people have also interfered in this after 1 or 2 decades of the 1954, 1964. And in 1970, between 1970 to 1980, the revised Jones criteria or modified Jones criteria is being implemented, where there should be the condition is this: okay, if you have got one major criteria and two minor criteria, but you have to prove that this patient has got the evidence, recent evidence of group A streptococcal infection, ASO titer, hyaluronidase antibodies, anti-hyaluronidase antibody, or anti-DNase B antibody, etc., or the evidence of the culture, so throat culture should be there. Modified Jones criteria. Already discussed the major criteria. I have already discussed this thing, and the minor criteria I already discussed. Now, coming to the treatment is concerned, the patient has got the problem now. First part is to solve the problem of the patient of the pain of the joints. Joint pain can only be relieved by the acetyl salicylic acid in the large doses. You have to give the patient in large doses of the aspirin. If the joint's inflammation is not resolved by the high dose of the acetyl salicylic acid, the diagnosis may be doubtful according to the experts, according to the Harrison's textbook of medicine. You give antibiotics to these patients. That is penicillins, that are a very good choice. If the penicillins, they are allergic, you will give the other one, that is macrolides, are they there, you can give the macrolides. If you are macrolides you cannot tolerate, you can give sulfonamides. So there are other options, but the most effective drug is the penicillin. In the any form of the penicillin. The most important penicillin is penicillin G, benzyl penicillin, in the acute, and followed by the long-acting penicillins. You can give the benzathine penicillin, which is the long-acting penicillin. You can give this penicillin monthly. But in acute phase, you give the penicillin G first of all, and then it is switched over to the long-acting penicillin. And you have the third thing you have to discuss is the prophylaxis. Remember that the aspirin also manage the syndromes chorea. This is very, very unique thing, because chorea is managed by anti-chorea drugs, levodopa and other drugs. They are effective therapy for the chorea management, but only chorea, syndromes chorea, is important with the acetylsalicylic acid. It responds with the acetylsalicylic acid. So acetylsalicylic acid will cure the patient rather, as far as the neurological manifestation are concerned. This is a very mysterious type of observation. So the aspirin higher dose is 4 to 8 gram per day for the adults, and it is 1 to 4 gram for the children. Continue the anti-inflammatory therapy until the ESR or CRP are normal. May need steroids if there is cardiac involvement, if pericarditis is there, for example, or sequel occurs as a mitral stenosis. Steroids, if indicated, are given at the prednisolone 2 mg per kilogram body weight for 2 weeks and then tapered off. Antibiotics, I already mentioned out about it. It is short acting and using the long acting afterwards. Otherwise, if it is allergic to the penicillin, you give the macrolide erythromycins. The other macrolides can also be given. So the other antibiotics other than that may be used also, cephalosporins, and the other antibiotics like sulfonamides can also be given. Prophylaxis is very important, needed to prevent the recurrence of acute rheumatic fever. To start prophylaxis after acute episode resolves, can use the penicillin V, which is oral penicillin, 250 mg twice a day, and it should be continuous. Or sulfarizine or penicillin G 1.2 million units. With allergic patients to penicillin, erythromycin 250 mg should be given twice a day as a prophylactic agent. Now, recurrence of the disease generally occurs in the first couple of years. And WHO guidelines is this is very important to understand. It should be given benzathine penicillin, which is given monthly, at least 5 years of the prophylaxis, or if the child until the age of 21. If not cardiac, if there is no cardiac involvement and you diagnose rheumatic fever, you will give the penicillin or substitute for 5 years, or the child become 21 years of age. 10 years prophylaxis, or if the child until the age of 30, if there is evidence of the mitral valve disease. is double करना पड़ेगा. 10 years of prophylaxis होगी, continuous benzathine penicillin monthly, या ये कि child की age 30 years की हो जाए, उस वक्त तक it should be given continuously. If there is severe heart disease, there will be lifelong prophylaxis. For example, the mitral valve, severe mitral valve disease or with mitral valve disease associated with the aortic valve disease, or mitral valve disease associated with the tricuspid or pulmonary valve disease. Or there was the evidence of the pancreatitis in this patient. In these all conditions, you have to give the prophylaxis for whole life. So duration of prophylaxis is in front of you, which I already said. In this chart, it is elaborated. Simple is that. If there is no cardiac involvement, 5-year prophylaxis, and or the child becomes 21 years of age. If there is evidence of carditis, 10 years prophylaxis, or the child becomes 30 years of age, or whole life if there is persistent valvular heart disease. Complications are valvular complications, heart complications, mitral stenosis, mitral valve regurgitation, mitral stenosis with mitral valve regurgitation, aortic stenosis, aortic regurgitation, or the secondarily the pulmonary valve involvement or the tricuspid valve involvement. So aortic regurgitation, aortic stenosis, and other valves may be involved in this disease. So the disease actually, it is central to the heart, basically. You have to save this patient for the complications. If the prophylaxis is done properly, the heart can be saved easily. This is the message which I can give. If you diagnose the acute rheumatic fever, please follow the WHO guidelines.